Hello, I'm Dr. Jehan Budak from University of Washington. In this National HIV Curriculum mini lecture, which is a revision of a lecture made with Dr. Kalapila, I am going to provide a brief review of prevention or prophylaxis of Toxoplasma encephalitis in people with HIV. This here will be the outline of this talk. I'll start with a background and rationale, followed by a discussion on screening and prevention guidance, medication side effects, and then finally a summary. Now diving right into background and rationale. Toxoplasma gondii is a protozoal parasite that typically causes an encephalitis in profoundly immunocompromised individuals. Although encephalitis is one of the most common manifestations seen with toxo, other clinical presentations, such as retinitis and pneumonia, have also been described. Toxoplasmosis is a foodborne illness. One gets exposed to the organism by accidental ingestion of cat feces or undercooked meat or raw shellfish. Once this happens, the organism forms tissue cysts in the brain, eyes, myocardium, and skeletal muscle, and these cysts can be present lifelong, and hence individuals won't be symptomatic. However, in people with advanced HIV who have these cysts, if their CD4 drops to below 100 and they are not on prophylactic medications, the cyst can reactivate and cause encephalitis symptoms, including fever, headache, altered mental status, seizures, etc. Now let's discuss screening for Toxoplasma exposure. Because of the risk of significant neurological disease with Toxoplasma encephalitis, the adult and adolescent opportunistic infection guidelines recommend that all people with HIV be screened for prior Toxoplasma exposure. This is done by checking serum for IgG antibodies against Toxoplasma. This slide shows some counseling you can provide to individuals who have a negative serum toxo IgG, i.e., they don't have a history of Toxoplasma exposure. Taking these precautions can help reduce risk of toxoplasmosis. Moving on to how to prevent toxoplasmosis if you have a prior history of exposure. For people with HIV, you would initiate primary prophylaxis for toxoencephalitis if they have a serum toxo IgG that is positive and they have a CD4 count that is less than 100. You need to have both these criteria in order to receive primary prophylaxis. And these here are the medication options for primary prophylaxis to prevent reactivation toxoplasmosis. The first-line regimen that should ideally be used is trimethoprim sulfamethoxazole, and the preferred dosing is to take one double-strength tablet daily. Note that this is the same dosing that we use for pneumocystis prophylaxis when the CD4 count is less than 200. So this is quite convenient that trimethoprim sulfamethoxazole provides prophylaxis against both PCP and toxoplasmosis. Alternative dosing options for trimethoprim sulfamethoxazole include taking a single-strength tablet once a day or taking a double-strength tablet 3 times a week. Alternative regimens for individuals who are intolerant of trimethoprim sulfamethoxazole include 2 options. One is a combined regimen of dapsone, pyrimethamine, and leucovorin. Remember here that you must check a G6PD level prior to administering dapsone, as if you give dapsone to someone with G6PD deficiency, you can cause a hemolytic anemia. Another issue with this regimen of dapsone, pyrimethamine, leucovorin is that it can be expensive, primarily driven by the high cost of pyrimethamine in the United States. The second alternative regimen for toxoplasmosis prevention for those intolerant of trimethoprim sulfamethoxazole is atovaquone. This can be taken by itself or in combination with pyrimethamine and leucovorin. Atovaquone is a liquid medication, and the main complaint that most patients have about this medication is that it tastes quite bad. It is an expensive medication, albeit not as expensive as pyrimethamine. Prophylactic medications can be discontinued if the patient is on combination antiretroviral therapy and has sustained rise in CD4 count to greater than 200 for at least 3 months. You can consider discontinuing prophylaxis for individuals with CD4 counts between 100 to 200, provided the patient is on combination ART, has achieved viral suppression for at least 3 months or more. So there may be situations when you discontinued the toxoplasma prophylaxis, but it needs to be restarted. These are the indications for when to resume prophylaxis. If the CD4 count drops to less than 100, toxoplasma prophylaxis needs to be resumed for patients with positive serum toxo IgG, regardless of whether they have viral suppression on ART. Prophylaxis also needs to be restarted for individuals with a CD4 count between 100 to 200 if they have a detectable HIV viral load. Now, let's go over some of the common side effects associated with the medications used for toxoprophylaxis. With trimethoprim sulfamethoxazole, you can see renal dysfunction, hepatitis or transaminitis, hyperkalemia, leukopenias, and particularly neutropenia. You can get a mild rash with this drug, or on the more severe spectrum, patients may have Stevens-Johnson syndrome. With dapsone, which contains a sulfa moiety, if an individual has a severe reaction to trimethoprim sulfamethoxazole, likely Stevens-Johnson syndrome, for example, you should not use dapsone. If the reaction to trimethoprim sulfamethoxazole is mild, like transaminitis or leukopenia, for example, then you can try dapsone. Methemoglobinemia can be seen with dapsone use. And finally, what we discussed previously was that individuals with G6PD deficiency taking dapsone can develop a hemolytic anemia. Atovaquone doesn't have too many major side effects except that it tastes bad. And lastly, pyrimethamine is expensive, can cause nausea and vomiting, and can also cause bone marrow suppression if not co-administered with leucovorin. In summary, let's review some key points regarding toxoprophylaxis. In people with HIV who are seropositive for Toxoplasma IgG, i.e., they have a history of prior exposure to toxo, primary prophylaxis is indicated when the CD4 count is less than 100, and that is to prevent toxoplasma reactivation. The preferred drug to be used for toxoprophylaxis is trimethoprim sulfamethoxazole. Alternative regimens include dapsone with pyrimethamine and leucovorin, or atovaquone, which can be administered by itself or in combination with pyrimethamine and leucovorin. Remember to always check a G6PD level prior to using dapsone to avoid risk of hemolytic anemia. Dapsone has a sulfa moiety, so if the patient is intolerant of trimethoprim sulfamethoxazole, your ability to use dapsone depends on the severity of their reaction to the trim sulfa. If it's a severe reaction, it is likely best to avoid dapsone use, but if the reaction was mild, then it's okay to proceed with dapsone. And finally, you should continue prophylaxis until the patient has achieved immune reconstitution on antiretrovirals.